All right. This case study is on colon cancer. So the patient is Mr. James Doe. He's a 58-year-old African-American male who presents to a primary care clinic for evaluation of some ongoing GI symptoms. He works a sedentary job, lives with his wife, and has no recent travel or known infectious exposures. He is a former smoker and has a family history of colorectal cancer, as his father was diagnosed at the age of 62. He reports experiencing intermittent abdominal cramping and some changes in his bowel habits over the past few months. This includes alternating constipation and diarrhea, as well as a sensation of incomplete evacuation. He also reports that he has recently seen blood in his stool that he describes as dark red streaks on the surface. Additionally, he has some unintentional weight loss of 12 pounds over the past 2 months and increasing fatigue. His father, as mentioned above, was diagnosed with colorectal cancer at age 62, which places him at an increased risk due to the first-degree familial history. Mr. Doe himself is 58 years old, which falls within the age range of increased colorectal risk. The median age for diagnosis of the cancer in men is approximately 66 years old, but recently the incidence has begun rising sharply after the age of 50, which has prompted the US PSTF to recommend routine screening start at the age of 45, putting him behind. He also has a sedentary lifestyle, and physical inactivity can be associated with slower GI motility, which can lead to prolonged mucosal exposure to potential carcinogens that are in the stool. Carcinogens from tobacco can affect not just the lungs, but also the GI tract through systemic circulation and direct ingestion. Smoking has also been linked to more proximal tumors and is associated with poorer outcomes. Colon cancer often develops from adenomatous polyps, which are typically asymptomatic and undetectable unless during routine screening years before they become malignant. Early-stage colorectal cancer also can be completely asymptomatic, making screening the only reliable way to detect precancerous lesions or detect the cancer early on. His missed screenings are representing a critical gap in that preventative care. On physical exam, Mr. Doe is pale and has signs of weight loss with poorly fitting clothing. His abdominal palpation reveals mild tenderness in the left quadrant without rebound or guarding. A digital rectal exam reveals occult blood in the stool, but no palpable masses. His vitals are normal besides mild tachycardia, which could possibly be related to anemia from the chronic blood loss. His conjunctivae appear pale, suggestive of chronic blood loss as well. All of these findings align closely with left-sided colon cancer. Mr. Doe's signs and symptoms, his risk factors, and physical findings are strongly suggestive of a diagnosis of colorectal adenocarcinoma, which is the most common histological type of colorectal malignancy, accounting for over 90% of cases. His clinical presentation is highly consistent with left-sided colorectal cancer, which is known to cause visible blood in the stool. The bleeding is described as dark red streaks on the stool's surface, which is suggestive of a lower GI source. Unlike in right-sided tumors that bleed occultly and chronically, left-sided lesions are closer to the rectum, which allows blood to remain visible and fresh when passed. He also is experiencing altered bowel habits of diarrhea and constipation, along with the sensation of incomplete evacuation. These are all hallmark features of left-sided obstructive lesions, as the symptoms often result from the tumor narrowing the lumen of the colon, which can lead to intermittent obstructions. Unintentional weight loss and fatigue are systemic symptoms that can reflect the metabolic burden of the growing malignancy, as well as the potential iron deficiency anemia from the chronic blood loss. Some diagnostics include a colonoscopy, which is the gold standard for diagnosis. In this patient's case, it would likely reveal an ulcerated friable mass in the sigmoid or descending colon. Biopsy during colonoscopy would provide histopathological confirmation of adenocarcinoma. A CBC would likely show microcytic anemia consistent with chronic GI blood loss. A CT of the abdomen and pelvis with contrast would be needed to stage the cancer and evaluate for local invasion or distant metastasis, especially liver to the liver or in lungs, which is common. And then a CEA is a tumor marker that may assist in monitoring treatment response and the reoccurrence risk, but is not a diagnostic on its own. Treatment is multimodal and tailored to the tumor's location, stage, and molecular characteristics. The goal is complete tumor removal, prevention of metastasis, and long-term surveillance for reoccurrence. Surgical resection is the primary modality. For localized colon cancer, surgery is typically the cornerstone. It involves segmental colectomy, which is removal of the tumor-bearing segment of the colon, and associated regional lymphadenectomy, which is typically removal of at least 12 lymph nodes for accurate staging. For example, if a tumor is in the sigmoid colon, it would require a sigmoid colectomy with high ligation of the inferior mesenteric artery. Surgery offers the potential for cure in early stages, such as stages 1 through 3, and is also used for palliation in obstructive or bleeding tumors in advanced stages. Next, sometimes adjuvant chemotherapy is used, such as postoperatively. It is generally recommended for stage 3 of the disease with tumor and lymph node involvement, or high-risk stage 2, where it is poorly differentiated histology. There's lymphovascular invasion or obstruction or perforation. The most common regimen of chemo is FOLFOX, which combines 5-FU, which is a thymidylate synthase inhibitor that disrupts DNA synthesis in the rapidly dividing cells, as well as leucovorin, which enhances the binding of the 5-SU to the thymidylate synthase, and oxalipatin, which is a compound that forms DNA crosslinks, causing apoptosis. Chemo together helps eradicate microscopic residual of the disease and would help reduce the reoccurrence risk. And lastly, surveillance and follow-up. After the initial treatments, these patients require long-term surveillance to detect reoccurrence early. These follow-ups include colonoscopy, which is typically 1 year after surgery, then every 3 to 5 years if no new polyps are found. CEA testing every 3 to 6 months for the first 2 years and then less frequently. And CT scans, especially in stages 2 and 3 patients, to monitor for distant recurrence, particularly in the liver or the lungs. And as always, early detection and getting preventative colonoscopies improves the chance of successful intervention and long-term survival.